So moving along, what is a bulle? Bulle is a big vesicle. So anything that's bigger than 6 millimeter, or in some sources, but most of the time it's going to be bigger than 1 centimeter. We call fluid-filled vesicle, then we call it a bulle. So big vesicle is a bulle. So what is the differential diagnosis for bulle? Well, the biggest thing to remember would be pemphigus, which can be pemphigus vulgaris or bullous pemphigus. And then of course there is additional things like burn can cause bulle as well, and then there is necrotizing cellulitis, fasciitis, or myositis, which is not included in the mind map, but we discussed it earlier in the talk. So what is pemphigus? Pemphigus is basically a life-threatening condition where there is acantholysis. So basically the hallmark feature of pemphigus is that there is separation between epidermis and dermis. So we call that acantholysis. In this condition, patients develop bulle, patients develop exudation of fluid, so there is a lot of dehydration associated with it, and there is a lot of risk of developing secondary infections. So whenever we see this, we need to stabilize the patient and treat the patient very quickly, because otherwise they may deteriorate very fast. The process basically involves circulating IgG antibodies, and that is what basically this immune-mediated reaction is what sets in the whole phenomena. There is an association with certain cancers, and then genetic predisposition plays a strong role. So there is an HLA type association with this disorder. So subtypes of pemphigus are going to be pemphigus vulgaris and bullous pemphigoid. Pemphigus vulgaris is going to be more severe. This is where there is going to be a separation of epidermis and dermis more pronounced. So the patient is going to have Nikolsky sign, which basically means when you press the skin area or when you cause any pressure on the skin, the skin is going to fall off literally. So that is called Nikolsky sign. There is involvement of the mucous membranes, oral mucosa, conjunctival mucosa is going to be involved. There is IgG antibodies against the desmosomes. So that is basically all pemphigus vulgaris. It's just the most severe type. So from vulgar, you can remember vulgaris, which is more severe. And you can see the patient is going to be more unstable. Bullous pemphigoid, on the other hand, is a little bit more chronic. Patients are going to be more stable. They may show bulle, they may have all kinds of symptoms, but they are going to be more mild symptoms. So patients are still going to have IgG antibodies, but these are against hemidesmosomes. The Nikolsky sign is going to be negative, although there is loss of adhesion between the dermis and epidermis, but it does not lead to Nikolsky sign. And then there is going to be skin involvement, but not the mucosa involvement. And again, patients are going to have more chronic symptoms, so they are going to have a recurrent bulle, and with the proper medication in the form of steroids, they may get better, and you don't always necessarily need to give them intense treatment. So this slide is basically showing the treatment for pemphigus, which is basically just an overall treatment. So the basic treatment is going to be skin care, prevention of infections, pain control. The next lineup is going to be systemic corticosteroids and immunotherapy or immune suppression. And the next line would be the biologic agents, which is basically additional chronic treatment in the form of mycophenolate and azathioprine, which are basically biologic agents. So what are pustules? Pustules are basically small, circumscribed, pus-filled lesions that show up on the skin. And pustules, like the name suggests, are filled with pus, so there is infection associated with it. They are seen in acne, skin infections, all kinds of different things. And so pustule is one lesion on the mind map, and we'll go right into the differential diagnosis. So here we're saying that there is acne where you can see pustules, and there is infections where you can see pustules. And I am not going to describe all kinds of infections associated with pustules because that will be beyond the scope of this talk. But almost any bacterial and even non-bacterial infection can cause pustules. So this is two specific skin conditions which occur as a result of infection. One is impetigo and the other one is erysipelas, and those are basically infections that cause pustules on the skin. And you can see impetigo is just basically circumscribed pustules on the face. Usually they are on the facial skin as a result of bacteria. We treat them for staph infection. And then erysipelas is going to be just widespread inflammation of the skin or resulting in cellulitis, and that is going to be just more dramatic and more severe, and we need to treat both these conditions with antibiotics. So what is a nodule? That is the next lesion on the mind map. So the nodule is going to be discrete, palpable, raised lesion which is more than 1 centimeter in diameter. Typically they are between 1 to 2 centimeter. If they are bigger than 2 centimeter, we call it a cyst or a tumor. So the differential diagnosis for nodule is on the mind map. We'll go right into it. And nodules can be isolated or they can be grouped. So the differential diagnosis includes acne, which we discussed in detail earlier already. So acne can have nodules, warts can have nodules, so we already discussed that too. Usually it's going to be human papillomavirus. And then additional differential diagnoses include nodules that are related to systemic conditions. For example, rheumatoid arthritis is one condition where we see erythema nodosum or nodules under the skin. There are additional conditions, for example, sarcoidosis, where we see erythema nodosum, but we are not going to discuss that necessarily in detail. Then there is benign and malignant skin lesions that are associated with nodules. Those are very important, so we'll go ahead and go right into the details of those. So this slide is just showing that the nodules can be inside or out. So there may be laryngeal nodules, there may be pulmonary nodules, which are basically found on a chest x-ray or a CT scan. A big wart is basically a nodule, and then rheumatoid nodules can show on the skin as well, as seen in the hands of this patient. So here is a skin condition associated with a lot of nodules, and this is called neurofibromatosis. So this is a condition where patients have nodules associated with different nerve endings. So a patient will have nodules all over the body, and they last all their life because these are basically the way patients have a genetic predisposition to them. You cannot cure them by excising them, so there is no need to excise these nodules. They are benign, so you don't have to treat them with any chemotherapy. They don't cause any other complications, but they may be associated with additional features. For example, cafe au lait spots, which are basically hyperpigmented macules on the skin. And there may be additional features, for example, Lish nodules in the iris, and they may also have additional systemic symptoms. So this particular patient on this slide, so here is, and they may also have additional systemic symptoms. So this particular patient on this slide has neurofibromatosis all over the skin on the face. Then you can see that a malignant nodule is going to be, one type of malignant nodule is basically basal cell cancer. So typically basal cell cancer shows up as a pearly nodule on the skin, usually on the face or other parts of the body too. And you can see that particular lesion right here, and we'll discuss it more in detail later. So now we can talk about additional skin cancers. So there is all kinds of skin cancers. A lot of them are going to have nodules, but let's go through one by one. So the first thing is going to be actinic keratosis, which is a maculopapular lesion, and it's a scaly lesion. There is no nodule involved. So this is basically a precancerous condition. Usually there is a scaly lesion on the sun-exposed area, forehead, face, or hand. So that is actinic keratosis. Then there is squamous cell cancer, where you will see ulcers, maculopapular lesions, plaques, and sometimes nodules. And then the biggest thing where you see the nodule is going to be basal cell cancer. And lastly, there is melanoma, which can also show in the form of nodules. So here is the risk factor for squamous cell cancer, and you can read that patients older than 60, sunlight exposure, ionizing radiation, immunosuppression, organ transplantation, chronic inflammation, and additional risk factors in the form of genetics, smoking, family history, diet, and HPV. These are the risk factors that are associated with the development of squamous cell cancer. So here is the risk factor for squamous cell cancer. So clinical features of squamous cell cancer is going to basically just involve a skin lesion, any non-healing ulcer, any skin break that does not appear to be healing over time should raise the suspicion of squamous cell cancer in a population that is at risk. So additional features could include papules, plaques, nodules, and there may be hyperkeratotic lesions. The location is going to be the first and the foremost is going to be head and neck area because that's exposed to the sun a lot. Then hands, dorsum of the hand and forearms, legs, and then additional body parts can be involved too. And these cancers are going to metastasize to brain, bone, lung, and liver. So just remember those 4 organs. So here is a typical squamous cell cancer that is on the skin, on face. It's a non-healing ulcer. This patient has had it for a long time, so it should raise a suspicion of squamous cell cancer. Another squamous cell cancer on the lips, you can see on the lower lip. Squamous cell cancer, believe it or not, can also occur in tongue. So you can see that the patient's on the under surface of the tongue is involved. And then lastly, it can metastasize. So here on the slide, you can see quite an aggressive squamous cell lesion. Basal cell cancer is the most common non-melanotic skin cancer, and the recurrence is very high. That's the thing about basal cell cancer. Also, although these are not going to be fatal cancers, they hardly cause death because they don't spread that much, but they are very disfiguring, and because they are so recurrent, we should treat them appropriately. So 40% of the patients who develop basal cell cancer will develop another one in 5 years. They are common in Caucasians. They are more common in females as opposed to squamous cell cancer, which is more common in males. And patients who are older, 55 to 75, are going to be at much higher risk of basal cell cancer. The risk factors are going to be almost similar: sun exposure, tanning beds, the ultraviolet radiation, and then immunosuppressive treatment, arsenic and ionizing radiation. Features of basal cell cancer are going to be that they are diagnosed based upon the biopsy. So whenever you see a pearly lesion or a lesion that you suspect is basal cell, then you should go ahead and biopsy it. 60% of the time it's going to be nodule, it can be superficial, it can be also infiltrative, so where they may be flat, but most of the time it's going to be nodule. A lot of the times they're going to be on the face, but sometimes they are on the trunk as well. So this slide is just showing basal cell cancer in different parts of the body. So this is basal cell cancer of the nose. So you can see there's quite a bit of disfigurement of the nose. We want to avoid it. This slide is showing basically all kinds of different skin cancers, basal cell, squamous cell, and melanomas in different parts of the body. So you can see for yourself that there is skin cancer on the ear. Then there is another one that is showing golden hue. Then there is an ulceration. Then there is another one with pearly nodule which has ulcerated. Then there is one that is on the lips which is ulcerated. Then there is squamous cell cancer of the lower lip. Then there is melanoma which is quite irregular. Then there is another melanoma on the sole of the foot in a darker skin color patient. And there is another melanoma on shin. Melanoma is basically the most common form of skin cancer. It is the most serious form of skin cancer because the morbidity and mortality associated with melanoma is quite high. The lifetime prevalence or probability is 1 in 37 in men and 1 in 56 in women. So in men it is much higher. It's the 5th leading cause or cause of cancer in men and 7th leading cause of cancer in women. So again, it's quite common. And 90% of the cases are going to be after the age of 10. So although it occurs in older population, it can also occur in adults and younger population. The risk factors are going to be sunlight exposure, ultraviolet radiations, intermittent sun exposure is worse than cumulative sun exposure. Then the family history or genetic factors play a role. Other skin cancer which are non-melanotic will also raise the risk here, and then immunosuppression treatment will also increase the risk of cancer. Clinical features of melanoma is going to be, these are going to be darker skin lesions, and there are subtypes. So there is superficial spreading, there is nodular, there is lentigo, there is acrolentiginous. To be honest and to be fair, we don't necessarily need to memorize all these different subtypes because there is going to be fair amount of overlap, and once you recognize it's a melanoma, you go ahead and make sure that you biopsy it. But the point of mentioning all these subtypes is just to make sure that we know that they are not going to always look like typical classic melanoma lesions. They may be flat, they may be superficial spreading, and this and that. Now we need to remember the ABCDE rule, which basically means they are going to be asymmetrical. There's going to be irregularity of the border. There's going to be a change in the color. If you see that, then you should raise a suspicion. And there is going to be a diameter of more than 6 millimeter, which is arbitrary. It may be more or less. Essentially, if the lesion is spreading and is getting bigger, then we should suspect it, and they should be evolving. So they're not going to be the same forever. They're going to evolve from one to the next stage. So whenever we see these A, B, C, D, E features, then we should start thinking about melanoma. Now, another thing is ugly duckling sign, which basically means that if a clinician looks at a skin lesion which appears like a melanoma or appears suspicious but is not necessarily following the ABCDE rule, then and is just looking very angry or looks like maybe there is something wrong with the lesion, it's more cancerous than benign, we should definitely go ahead and proceed with caution and take biopsy to make sure it is not melanoma or cancer. Melanoma can also be present under the nail. So this is a melanoma under the nail bed, and you can see by looking at the unusual appearance of the lesion. So this is just showing all the 5 features A, B, C, D, E of melanoma. This is spreading, this is evolving, this is darker color, this is the color is changing and the depth is changing, and it's very asymmetrical with irregular borders. So this is basically the overview of treatment of different types of skin cancers. So the treatment options are going to involve surgery, and so that is going to be the baseline or the hallmark of the treatment. So Mohs surgery is the most common surgery. It is micrographic surgery. Then you can also do curettage and electrodesiccation. Then there is topical agents, for example, 5-fluorouracil, which is used typically for actinic keratosis. Then there is photodynamic therapy, there is cryotherapy, there is radiation, and lastly there is chemotherapy and immunotherapy with MAB agents. Those are used more for extensive spread of the cancers. For example, if there is metastasis, then we use chemotherapy as well. Now lastly, this slide has an image that shows the letter H, which is basically the H zone. These are the high risk areas. So this means that if the patient has a cancerous lesion in this H zone, then patient's risk of developing recurrent lesion or metastasis is going to be much higher. So remember this H figure, and if the lesion is there, then we need to be extra cautious or careful. On the other hand, if the lesion is in the M area, which is outside of this H zone, then that is not a high risk zone. So when it comes to cancers, lastly worth mentioning is Kaposissarcoma. So Kaposissarcoma is a lesion that occurs as a result of a virus infection. Typically, it is going to be HIV or human herpes virus, and that happens because of immune modulated mechanism that involves these viruses. So Kaposissarcoma is going to be purplish, reddish blue color lesion that is going to usually spread on the skin in the form of a nodule, plaques, or macules. And these lesions are going to ulcerate and bleed very easily, and that's how you recognize these lesions. Usually patients already have a history of HIV infection or other herpes infections, so that is how you can make the diagnosis. But most of the time, you are going to need to do a biopsy to make the final diagnosis of Kaposissarcoma. So this is different types of Kaposissarcomas. They can be present on the ankles, on the heels, on the feet, on the extremities, and the treatment is going to be, of course, surgical and then immunotherapy and chemotherapy.